Okay. So today we're going to start with the kidney. This is kind of well, knock on wood, the good day. This is kind of where we just get a lot of the anatomy out of the way. And I think we do pretty well with anatomy. It's the diseases that we have a hard time with. A couple of you, more than one of you have contacted me. One person didn't somehow, and we don't know how, turned in homework without finishing it, although they were pretty confident that they had finished it. Another person didn't submit it. Guys, we're going through we have enough going on our plates, you and me, so just get it done. And if I have to send it back and send it back to you or tell you to finish something up, don't worry about that. That's just I just want to make sure that we're doing something, getting some work done. All right, kidneys. Let's start. It's a multimedia display today. More than one sketchbook going on, a PowerPoint, images only, so it's the good kind of PowerPoint. At least I think so. All right, kidneys. Kidneys are interesting, and some of the anomalies that we will have, we'll talk about normal kidneys first, but some of the anomalies we have is ectopic kidneys. In other words, a kidney in the wrong place. And like so many other ectopics, it's because of migration. The kidneys start in the pelvis, and there's actually a whole three-part production of the kidneys, but we don't need to go over that now. Actually, we'll go over a little bit of that in embryology in next semester. But suffice it to say, they start in the pelvis, and sometimes they don't leave. And so if you ever are looking for a kidney that you can't find, look in the patient's pelvis. It might still be there. So they migrate up from the pelvis. It also causes some some issues in attachment of blood vessels, or how many are attached. It's one of the reasons why some people have many or multiple vessels, is because of the migration and an incomplete migration, or an incomplete neovascular formation with migration. Each kidney is not that big. You know, when we look at them on the screen, they're zoomed up. We have a big screen. We start to think of them as being fairly large organs. Well, if you ball up your fist, that's about how big it is. The length for men and women in the general vicinity of 10 to 12 centimeters. And that, once again, is the more important measurement, is the length. Just like the length of the liver and the length of the spleen are the most important measurements, the length of the kidney is the most important, although we will do all of them. Pay attention, and I'm trying to stick to the order of the book here. So if it seems like I'm jumping around, it's not me, it's the book. We pay attention to any size differences in these two kidneys. If one kidney, and notice I have, by the way, this kidney's a little bit higher up. That's on purpose. Let's say my right kidney is 12 centimeters in length, and my left kidney is 10. In that situation, that is a 2 centimeter difference. Anything more than two centimeters or more in length is an indication that the smaller one, the smaller kidney is diseased, dying, or perhaps even not getting enough blood supply to it, so it starts to shrink. So we always check, we always take our measurements, see if they're within normal range, first of all, and then second of all, any kind of major difference in the size is definitely notable. I had a kidney that I found, and the fact that I found it was 100% luck. I don't take credit for it. It was about the size of a kidney bean on an adult. So it was an absolute, it was very strange, perfectly formed, absolutely tiny kidney. And it was probably not even really functional, even though it was perfectly formed at that size. It just didn't make any sense. And I never got an explanation as to why a kidney would do that. That's a very unusual thing to find a perfectly formed, tiny kidney. Usually if the kidney's small, it's because of atrophy. I almost said hypertrophy, atrophy of the kidney due to disease, and then it certainly doesn't look normal. You know, the kidney has some fascias around it. There's the renal capsule itself. The renal capsule. So that's can I draw on this? Yes. Listed here in that little blue right around the kidney itself. That is the capsule. The perirenal fat everyone has. You have to have it. It's a requirement for the job. Now, perirenal fat you have to have because that really protects that kidney. Then the renal fascia, there is an anterior renal fascia, and this is still underneath. The dotted line is the parietal peritoneum. Well, at this point, it'd be parietal peritoneum. Peritoneum, in any case. So let me go ahead and label that. Dotted line is peritoneum. But the red line is renal fascia. Now, renal fascia has two different names, a couple of different names actually. I think I found three. The only one that I'm even really familiar with is Gerota's. Gerota's fascia. And most people, whoops, it's the red line. Most people, most books will actually call it all Gerota's fascia. Technically, you know, I think the posterior fascia has a different name, but we're not going to worry about those kinds of little things. Just know that there are different fascia planes. And so there's perirenal fat. Let me tell you something about the perirenal fat. It can be rather echogenic. It could be hypoechoic. And that sometimes has to do with body habitus. Sometimes may have to do even with disease state. You know, when fat is really echogenic, perhaps it is well, no, let's stop where I'm ahead here. In any case, just like around other inflamed organs, the pancreas, the fat can become even more echogenic than normal. But in any case, the fat around the kidney has a range of appearances. All right. So let's see, renal capsule, continuous ureter, perirenal, perinephric fat, it's also called. So perirenal, perinephric. Perinephric fat is another term for it. Okay. So that's all on fascia. Now the book talks about, and it gives you this couple of these pictures. I've kind of redrawn them a little bit to, cool, let me just get rid of some of this. That is a big eraser. Let's make that a little smaller. All right. The book gives you this picture, and there's a posterior. This is an anterior picture. In other words, you're looking straight down on both kidneys. Both kidneys have a supra section, suprarenal. That's really what they're talking about there. I did some drawing here ahead of time. Come on, baby. That's where the adrenal glands sit. So each kidney has a little cap on it, looks like a little cap, the adrenal glands, and they're sitting up over here. There's a little bit of space between the kidney and the adrenal gland, and there's some fat in between. Interesting to note, though, Gerota's fascia, or the renal fascia, surrounds the adrenal too. So that adrenal is within the fascia plane. So it's kind of interesting. So that's where the supra surface is on both kidneys. And then, well, on this side, the hepatic, HEP for hepatic, well, what does that mean? That kind of means that that's where the liver is going to sit. Liver is sitting, I probably could have, you know what, I can move this liver. Let's move the liver. It didn't move. Now it moved.
What did you say those caps were on top of the supra area?
The adrenal glands.
Okay, thank you.
Mm-hmm. Yeah, let's go ahead now. I might as well tell you now, the adrenal glands are seen in utero, in fetuses, and in babies. If you see an adrenal gland on an adult, either you're scanning unbelievably well, or there's something wrong, and it's the adrenal gland's too big. So I've only seen a couple adrenals on adults. Both times it was because there was an adenoma growing on it. So instead of being fairly thin, it was enlarged. So yeah, the liver is sitting on top of the kidney for the most part, and this is the area where there's an actual indentation in the liver itself from the kidney, and probably the kidney itself has a slight indentation from the liver laying on top of it. So that's the liver surface. And over here we have a splenic surface. And so if we add that in, we now have a spleen sitting over here on this side. And that's where the kidney is kind of into it. Probably, once again, I probably could have moved that a bit. Let's just kind of slide that up a bit. It's kind of higher up. Okay, that's enough. Enough messing around with it. So there's the splenic surface, and let's see, what's the next one I have? Oh yeah, so I don't know if you could read that, for pancreas. Oh, that's why I had that down there. Let's see, can I just hit Control Z? There we go. The spleen was there for a reason, because the pancreatic tail goes to the splenic hilum. Both the pancreatic tail and the splenic hilum are anterior above the kidney, and so the kind of the tail of the pancreas lays on top of the kidney at this point. So that's why they call this the pancreas area on the left kidney. All right, what's next? Oh, this is one of my worst stomach and duodenum images I've ever drawn, but let's get rid of that just for a second. Gastric. On the left, left kidney, we have a gastric area.
And just to clarify, everything that we've put up so far, liver, spleen, pancreas, all that's anterior to the kidneys, right? Because the kidneys are in the retroperitoneal area?
Yep. You know what, I didn't draw, I just think it's less important for us, but the posterior to the kidneys is basically ribs and psoas muscle. So it's Yeah, these are all on top or anterior. So we have our gastric area on this kidney, and then we go over to the right kidney, and we have this duodenal area. The duodenum's a long area. Well, that's the C loop of the duodenum here. So let's put that back up there. Obviously, not everything's placed perfectly right because the head of the pancreas should be folded into the C loop, but you get it. So here's our gastric impression on the kidney is right over here, and then as it comes across, here's the loop of the duodenum, which, yeah, depending, that's why we get our patients up on their side. That moves the duodenum away from the kidney so we can see it a little better. I think it's more of a medial anterior because the duodenum doesn't usually get in the way of the kidney, but you get the idea. Okay, let's see, what was the next one? Oh, the duodenum. So the duodenum is the first part of the, or duodenum, whatever, is the first part of the after the duodenum, small intestines, and it's going to swirl all around up here, up high, and so I just I drew a little bit in there, and it's covering the kidney here, and it's going swirling around and covering the right kidney down here. And then let's see, next one, colon comes around. So that colon comes around, that touches the kidney as well. That guy, both the duodenum and definitely the colon do get in the way of the right kidney lower pole. It can be very difficult to see, so we have to move students for the last few years, but patients around as much as we can in order to get rid of that gas. And the same thing, a little bit of colic interference on the left kidney as well. And then what else do I have? I think that's it. That's it. Let me back it up just a little bit. Well, so I figured I'd draw this out because sometimes I think this is, it seems easy enough when you're really into the anatomy and how everything fits together. But I remember as a student looking at these images of the kidney and the areas of the kidney and not really understanding it. So hopefully this kind of helps you figure out how each one of these layers lays
and
on.
we're still looking at that we're still looking at this image through the anatomical position. We're not looking through their back, like we'd be looking coming down from their stomach, right?
Yep. This is like your Superman, you're looking straight down at him. So in other words, an impossible ultrasound image here because of the way everything is set up here, but yeah, pretty much an anatomical view. Well, on this particular just checking on everything here. On this particular, sketchbook, that's all I've got. The next sketchbook's got a bit more. Do we want to save changes? Sure, I guess. Oh, that's right, I did draw on it a little bit. All right. Okay. Most of this was the magic of copying and pasting, so I didn't have to draw this over and over again. Let's see. These two are the same. Well, they're obviously one's right and one's left, but they are the same. Oh, by the way, the left kidney is higher, the right kidney is lower. That's simply because the liver is a bigger organ, and the kidney has to be lower because of that. Okay, so a kidney, it's, well, let's see, it's hilum. Let's make sure I'm. Okay, yeah, I'll just mention. So the hilum is the doorway, right? The hilum of the liver. It's not always called the hilum of the liver. It's the what do we call it? In any case, I usually call it the hilum. That's why I'm confused. Anyway, the hilum of anything, the hilum of a kidney, of a lymph node, of a liver, it's simply kind of the doorway to and from. And so obviously arteries are going through the hilum, veins, lymphatics. This is ureter coming in through the hilum. So that's just the doorway. And so when you ask for the hilum, it's a picture of nothingness. It's the picture of the doorway itself. So that would be the hilum. Obviously, I don't need to indicate which is artery and vein. We have an artery and vein coming in here. And then we have a whole bunch of other things. So let's just kind of work our way through. And, well, let's see. We already mentioned the renal capsule. Between the renal capsule and the, well, let's go ahead. Let's do, we already mentioned this the other day. That's the medullary, the medullary pyramid is here. And this is the base of the pyramid. Even though it's upside down, it's still the base of the pyramid there. Between the base of the pyramid and the capsule, that is the cortex. And that always confuses me, honestly, because when I think of cortex, I think of the core. The apple core is in the middle. The core of the earth is in the middle of the earth. Well, the cortex of the kidney is on the outside. So if you think like me, you have to kind of slow down and really think about that. Now, that's one of the, actually a measurement we could take, a cortical measurement from the capsule down to the base of the pyramid. And because that's really where the business is going on inside of the kidney. This is where filtration occurs, and it's one of the more important parts. The pyramid itself is where the urine is draining from the filtrate up here in the cortex. It's draining down the pyramid and into the ureter. So let's see. I think we mentioned this before. Let's do it again. The distance, I'll just go ahead and take out here on the corner here. The total distance, everything from there to there is the, whoops. The parenchyma, you know, the tissue. Now, this is really important. For a number of years, I was taught wrong. Everyone I worked with was taught wrong. We were all supposed to, they say, hey, let's do a cortex measurement. And what we were measuring is the entire thickness. That's not a cortex measurement. That is a parenchyma measurement if you measure the entire thickness. I finally, and all of us, like up in Colorado, the last place I worked, there were 20 of us. It was a big hospital. And we were finally all learned right by the pediatric radiologist. She says, no, you guys are not measuring the cortex, you're measuring everything. The cortex is only from here to here. And that's an important measurement in cases of renal disease, because in renal atrophy, because that's what thins out with renal atrophy. Atrophy is atrophic, like sitting at home for more than a month, my muscles are atrophying because I can't muster up the chutzpah to work out can't do it without going to a gym. I don't know why. Am I going off in the weeds a little bit? All right. So we got the capsule, the pyramid, the cortex, the parenchyma. Let's talk about this guy here. We're going to call that the renal pelvis. Now that pelvis is the, let's see, the proximal end of ureter. The proximal end of the ureter is the pelvis. And it's a, you know, it's a bit medial and medial to the kidney, and it goes in and becomes part of the kidney, of course, but we call that the pelvis itself, and that's the collecting system, is the pelvis, which is different than, I guess these drawings have a little bit too much on them because it's hard to point out. I'll go ahead and use this one anyway. I'm going to go ahead and point to, all right, never mind. I'm going to use this guy down here. So pelvis, collecting system, what we're going to call this, well, that's technically what I'm on right here is okay, fat. We have fat outside of our kidney. We have fat inside of our kidney. And the fat is located in the sinus. So this whole area is the renal sinus. It contains fat. It contains branches of the arteries and veins, the segmental branches. It contains the collecting system, which in this case we have the pelvis here. We'll basically, let's just call this area the pelvis. So that's all in the sinus, the renal sinus. You know what? Let's zoom in on this guy a little bit more. We'll continue to use this one. It's a little cleaner to look at. So each pyramid drains. So at the bottom of this little, well, at the apex of the pyramid, of course, some pyramids are upside down, some are sideways, and some are right side up, just from this picture. But the apex of the pyramid itself, that is called the papilla. I just can't stand that. Papilla. I know we're in El Paso, it's not papilla, it's papilla. That is the part that sticks between the parenchyma. It sticks out of the parenchyma and into the collecting system and really becomes part of the sinus. The papilla itself is inside of the sinus. And so that little tip right there, that little tip right there, and tip right there. By the way, these guys can be really confusing. They can be an echogenic, and so you see these little echoes, and you think, oh, there's a stone. There's a non-shadowing stone. No, it's actually probably the bottom of the. Even though the pyramid itself is usually hypoechoic, once it comes through, pops through, it looks echogenic right there. So then we have the very beginnings of the collecting system are the minor calyces. calyces, or calyx, the minor calyces. And then they drain into major calyces. Not mejor. Sorry, I'm feeling a little just punch drunk today. Let's see, what else have we had in the ureter itself? Oh, the columns and the ureter. Okay. Let's just I've made this ureter awfully fat. It's, once it comes out of the kidney, it's not nearly this fat, but let's just pretend this guy has what's called hydroureter, which is urine backed up in the ureter. But once it comes down here, this is the ureter, and of course that goes all the way down to the bladder. Here, let's use left kidney here. This guy's not doing anything except for just looking pretty. I forgot to mention one thing. So we have the cortex, we have the parenchyma. If you're going to measure thickness all the way across, it's the parenchyma. But in between the pyramids, the medullary pyramids, are columns of tissue, really, because they're not quite cortex, they're not pyramids, they're still considered part of the medullary layer, which I don't like to say that because it gets a little confusing, but the whole medullary layer includes this area and the pyramids too. These are columns of Bertin or Bertine, I don't know. Whoop, that's an R. I can't do it. All right, B-E-R-T-I-N, columns of Bertine. And so basically, that's a column of Bertin. This is a column. I guess at the tip is a column too. There's a small column there. This is a column. All of them technically are columns, just simply because they're kind of placeholders. They're kind of structural, physical structures that holds the kidney all in place. Let's see. We talked about the vascular yesterday, so we don't need to rehash that. Okay. Oh, and so, one thing I'll mention also is, so this fat, and there's so much going on in the sinus. The whole thing is the sinus. And including the fat, including everything, the sinus is echogenic, unless you're a infant, maybe a toddler, but more likely an infant, because infants don't have any fat in their sinus, and so their kidney looks different. There's other things that look different about their kidney too. Oh, and the book on page, I have a little question mark written right in my book because it didn't make any sense. When something doesn't make sense, I always mark it because I want to make sure that I bring it up to you guys. On page 277, renal cortex. The normal adult renal cortex is homogeneously echogenic. No, it is not. And I wouldn't even call it homogeneously hypoechoic either. It's isoechoic, to the liver, and it's pretty close to isoechoic to the spleen. So if I had a liver, a healthy liver, obviously an unhealthy liver, then all bets are off on the echogenicities. But echogenic, no, that's an error. They just simply made a simple mistake, and I'm not sure what they're talking about. Because in fact, an echogenic kidney, if this is echogenic, there's either one thing: you're a newborn. Newborns have echogenic kidneys, or can have, or you have a seriously diseased kidney. Diseased, or perhaps an overdose on certain drugs can cause echogenicity of the cortex and the parenchyma. Then there's different types that causes the different disease states, which causes the pyramids to be echogenic. I had a student, my first class at Pima, and I just finished talking about a certain disease state. We go in, and I'm walking around, and I look over, and she's got it. Fortunately, it's a very benign state, but it's just funny. So speaking of benign states, or mostly benign states, I have some anatomical variants that we need to be aware of that I've drawn out here. This guy has two anatomical variants. This one, I probably could have drawn a little bit better, but yeah, this is pretty good. The only thing is, remember, urine's not going to be yellow on the screen. It'll be black, right? Anechoic. It's yellow just because that's how I wanted to draw it. This is a extra renal pelvis. So the pelvis normally more or less in the kidney or in the doorway, the hilum, maybe just slightly out of the kidney. But some people simply have a pelvis that bulges way out. And the thing that we have to know about is that it is almost always, in fact, I will put always, filled with urine. So, in other words, if you have an extrarenal pelvis, you always have a cystic appearing structure just on the outside of your kidney, right where you would expect it to be. And so these are pretty easy to determine that it is an extrarenal pelvis because it's right here. It's never up here, never down here, always right there. And if it's right there, then we could pretty much assume that we have an extrarenal pelvis we're dealing with. This person also has a dromedary hump. A dromedary hump is what camels have. So this is basically, they say it looks kind of like a camel's hump, and so they call it a dromedary hump. My lovely kidney hump. All right. Important to know if it's a dromedary hump or is it cancer? So we need to determine that. If the echogenicity is the same, that is probably a dromedary hump. If it doesn't have if it looks more like a lump and is not dramatically changing the architecture of the kidney, of the internal portions of the kidney, it's probably a dromedary hump. If it's cancer, it's a little more round perhaps. Things are being pushed away, so these structures are all going to be pushed away from the cancer because it has a mass effect. The other thing we want to know about is this guy. So this is simply a column of Bertin. So a hypertrophied. In other words, it's increased in size. Column of Bertin. That's an N. No, it's an M. All right, well, you know, column of Bertin. And so that's here. Once again, is it isoechoic? Question mark. If it's not isoechoic, then we can't assume that's a column of Bertin. It's also the column of Bertins almost always occur mid-pole. You don't really find them up at either end, and they jut inwards. The dromedary hump juts outwards. Oh, and there's a reason why I chose the left kidney for the dromedary hump. It's many of our organs grow to the space that they have to some degree. I mean, a kidney is always going to look like a kidney, but to some degree it grows to the space that it has. The right kidney has a, if you could see me, has a liver laying down over the entire thing. You are not likely to get a dromedary hump with a liver laying on top of it. On this guy though, if I could draw a spleen real quickly here. Okay, that's not really what the spleen looks like, but if the spleen were laying on it, it might be laying on the superior or pole, the upper pole of the kidney, and this lower or this mid pole has the room to grow that direction, so it will grow that direction. So more likely to be found on the left kidney. Okay. Let's see. 144. Oh, this is awesome. All right, back to this guy. I didn't originally plan for let's just get rid of some of that stuff there. Okay, the kidney, not only does it migrate, but it grows from several different buds. Those buds come together, and if there's an incomplete fusion, this is like a cleft lip, except it's a junction. I said cleft, and I couldn't think of what it's actually called. Junctional parenchymal defect. They will be echogenic because they got filled with fat. So you can't just, in the body, you can't just have a defect and nothing's there. There's always something there. And so in this case, kidney is surrounded with fat. Fat will fill the space here, and more often than not, it will be echogenic. So these are not unusual. One thing I didn't draw, it didn't come up, and maybe it's just later on, but a more extreme example of this, let's quickly, yeah, let me just quickly draw another kidney. Whoop, you get the idea. Nope, you don't. That's horrible. Here, I'll just draw the. Oh my God. All right. Can't do it quickly. In this case, the junctional defect is it's not just a defect, it's an actual lobulation. And these are actually called, and fetuses have these, little babies have these. These usually grow out, you outgrow these, but sometimes you don't. And so if you don't, they're called fetal lobulations. And it's just really just the kidneys just kind of, you could see that there's several different original buds that grew together and just failed to come together. Even more than a junctional defect, they just, like, the entire section is separate. So those are fetal lobulations. Sorry, I didn't plan on that one. I honestly didn't think about it until now, but wasn't the book, wasn't my fault. The last one for now is a double or dual. Let's just do double collecting system. So this can happen, and this is probably somewhere in the realm of an incomplete fusion as well. But double collecting systems do occur. They're not actually unusual. When what could happen with these are a couple of different things. Let me just show you something on here. One thing that can occur is that, that's not quite right. Very quickly, or maybe halfway down, the two separate ureters can fuse together and become one ureter. You're probably better off if that happens, because the alternative is that these two stay separate all the way down. And what happens is, for some reason, the upper usually has some problems at the far end. So it comes all the way down. And when it comes into the bladder, it doesn't come in the right spot, nor does it come in correctly. And it can cause a backup of fluid. For some reason, I was going to look up the Latin. I'm sure it's Latin. What happens is we get hydronephrosis. Hydronephrosis is varying amounts of fluid buildup in the collecting system. So let's write that down. Hydronephrosis can be minor, it could be dramatic. What I was going to say about the Latin term, they always refer it as to the upper moiety. And I forgot to look up the Latin meaning of the word moiety, but that's how they refer it. So the upper moiety oftentimes has hydronephrosis in a dual or double collecting system. And this is one way to really know that you have a dual collecting system, is if there's a little bit of fluid stuck in this one. Not that it's ever good for the patient, but at least it tells you that you're not simply looking at a hypertrophied column of Bertin, because the two appearances are actually very similar. Oh, I was going to talk about, you guys have a test today though. And that. So
And then ureter is going down into the bladder,
Yes.
the ureters. And then what did you say the hydronephrosis was? Just a backup of fluid?
Yeah. Yeah. So urine. Yeah. Back up in kidney, and then hydroureter is when that in ureter, obviously. So hydronephrosis refers to fluid up here. Hydroureter refers to fluid down here. Usually, if you have hydroureter, you have hydronephrosis too. But if you have hydronephrosis, you don't necessarily have hydroureter, because so often hydronephrosis, well, and this is a double collecting system, that's an exception. Hydronephrosis so often occurs because of a kink, or maybe even a stone, a kidney stone, kind of right here. And so fluid can build up in the collecting system all the way up here, but not in the ureter because of this, because that's where the problem is. If the problem is all the way down by the bladder, then you get fluid back up all the way up the ureter from the bladder. We'll talk another day about why this occurs. There's different reasons for it, but in this case, it's not specific. So I have another page in notes. You guys have a test today, and the second page is probably just a little bit more. Well, we're talking about some hormones, very little bit about the nephron and the basic functions of the nephron. And that gets a little bit more difficult to follow. So how about this, guys? Let's not take a break right now. I just have a very simple PowerPoint presentation, and we'll go through that, and then we'll open up the test and 20 minutes, half an hour later. So that sound like a plan? Probably does sound like a plan. Any short day is a good day. No, but I think we got some good stuff done today here. And even though it's a short day, tomorrow will be probably a little tougher, but I know it'll be tougher. Okay. Great pictures, though. Where's my little pen? Oh, how did that? Didn't touch anything. Let's just get a spotlight here. Okay. All three sagittals, all three normal. Here is, and obviously not, the cortex is not echogenic. So the book just simply it's just a simple mistake, no big deal. It's more, if on these pictures, more hypoechoic than anything surrounding it. So on this person, we can clearly see the no, I actually have it. I do have it in this PowerPoint. The cortico-medullary junction. The cortex, medullary, this is medullary pyramids, and these are medullary columns, or columns of Bertin. The junction is easy to see. I could easily take a measurement of this person's cortex. This person's cortex, a little more difficult. I can kind of see it in places. I can get an idea. Ooh, a little bit of a column of Bertin here. Little bit of a column of Bertin, but I wouldn't even call them. These are both rather small. They're not really hypertrophied so much. You can see the sinus mostly filled with fat and echogenic. So anyone who tells you that finding a small stone in a kidney is easy is lying to themselves. You can't find small stones inside of this unless they're shadowing and or twinkle artifact. If you put color on, you get a twinkle artifact. Notice also kidneys have a nasty habit of creating this dirty shadowing. I don't even know why. Dirty shadowing is normally associated with air. Certainly not air in the kidney, but there's definitely a dirty shadow oftentimes out of a kidney. That just makes your job a little harder too. Traditionally, this is how I've always measured the kidney. I get a long kidney along with the liver. We have one location in town who does not want us to do it that way. So we're going to learn different ways of measuring this kidney. This kidney does not have an echogenic sinus. This is most likely a young pediatric toddler, or if not baby. Maybe not a newborn, because the echogenicity of the kidney itself is close to that of really close to the liver. This is a little bit of, yeah, that should be liver. This is a little bit of liver tissue right here, pretty close in echogenicity to the cortex, so the renal parenchyma as well. Transverse pictures is all we do is turn around. So we have liver up here. Kidney is C-shaped in transverse. Echogenic sinus, and we can see most likely this is the vein coming out. Veins are a lot easier to see because they're so much bigger than the arteries. There's another beautiful picture of a liver, gallbladder over here. Transverse kidney with perfectly isoechoic between the liver and the kidney. This is definitely a renal vein, because you could actually see it go all the way back to the IVC. You can see how, this is a thin person anyway, but you could see how close everything actually is when you realize that this person's right renal vein is only about maybe 2 centimeters long, because that's where the IVC is on the right, the kidney's on the right, they're right next to each other, and so that's how it is. Now, of course, this person's right renal artery has to start over here. Oh, there's a little bit of it right there, actually. Right renal artery starts over here, comes across. So the right renal artery is longer, but on the left side, the left renal artery is very short because the aorta is on the left. That's cool. Yeah, little renal artery right there. Now, given orientation of this one, this has got to be the spleen. Either that or someone's holding their transducer backwards. But I say it's a spleen because the C is now facing this direction. So the hilum faces the medial. So this, you know, assume this is the person's left side. Medial is going to be here, and the C is facing the medial aspect of the body. Normal cortico-medullary junction. That's what I mentioned before. And so here, look at this. We clearly see the red dot is the cortex. When it goes from cortex to pyramid, that's the junction. Down here, we can clearly see these guys are so high. careful. These guys are so hypoechoic, they could actually be confused as cysts. So you got to be careful. Sometimes we usually don't see pyramids this clearly, because that's really beautiful. So by the way, let's see, right kidney. We know that this is liver, anterior to the kidney, superior to the kidney. Posterior to the kidney is going to be muscle. This is a very hypoechoic, I know, but this is psoas muscle here. And look at that, the psoas muscle right up against the spine here. And that makes sense. Kidneys are very close to the spine, but they have muscle in between, the psoas muscle. And here's the spine. So even though we're looking through the patient's side, we're looking all the way through the side down to the spine at this level. Here's our dromedary hump. Oh, this is really cool, actually. So spleen here. Whoops. Well, spleen there. You can clearly see the spleen actually. It's almost like it really caused that dromedary hump over here. So that at first glance looks like cancer, but when you really look at it and say, oh, you know what? No, it's not cancer. We're fine. Interestingly enough, edge of kidney, medial edge of kidney, aorta. Well, once again, even though we're actually looking through the patient's side, and this is another thin patient, but even though we're looking through the side, we're actually looking through the side all the way down the aorta, and then spine would be here. Another nice dromedary hump. Oh, yeah, left kidney. I was going to say it looks like the left kidney, but clearly is. And, oh, that's right. And someone added the camel in. They actually did a nice job. Let's see if I press this button. Nope. Don't worry, by the time we go back, I'll understand how to use this. Hypertrophied column of Bertin. Guys, this would catch my eye because not only is it a hypertrophied column, but it's rather round. Don't like seeing round things, round solid things in the kidney because that's usually more of a neoplasm or growth. But it is in fact a column of Bertin. It's perfectly isoechoic with the rest of the kidney. By the way, cortical medullary junction not well seen at all on this patient, and that's very common. That's a common occurrence. Another column of Bertin, but this one really goes all the way across. So that makes me wonder. This one, column Bertin, goes pretty much all the way across, but you can see there, it looks like there's still a little bit of sinus fat or sinus anyway going through those upper and lower moieties. So is it a hypertrophied column of Bertin or a supernumerary kidney or a cross-fused ectopic kidney? So in this case, this is a upper pole of a right kidney, kind of along here. Anyway, upper pole of a right kidney along here, and then a second right kidney kind of right up against it. Now, this could be a cross-fused ectopic. You don't really know until you go over. Now, if this person has a left kidney, then it's a supernumerary kidney. Supernumerary kidneys could be separated. So kidney, like two right kidneys to separate it, and then a left kidney. That's a possibility as well. Here again, kidney with another kidney, really growing right into each other. This could be cross-fused ectopic. It could be both the right and the left kidney on one side, and they've grown into each other. And that happens because it's all kidney. And so the kidney doesn't recognize the fact that it's the right kidney doesn't recognize that the left kidney shouldn't be there. It just says, oh, your kidney as well. Well, let's grow together and do what we do. Awesome view here of, well, let's see. On this side, we actually have a common trunk, but 2 renal arteries on the right. On the left, on this supernumerary kidney, we have 2 collecting systems, but it's not a normal kidney with 2 collecting systems. It's actually 2 kidneys, each with its own collecting system. So it's a little bit of a difference, but these 2 collecting systems do actually fuse before entering the bladder. So that's probably a good thing for the patient. Oh, and of course, 1, 2, 3 renal arteries on this person's left kidney, which is pretty cool to look at. So dual collecting system. In fact, I think this might be the same picture as I used for hypertrophied column of Bertin. So sometimes you'll see a hypertrophied column of Bertin and say, ooh, dual collecting system. Look there. There's an echogenic sinus here and an echogenic sinus here, and they don't meet, so therefore it's a dual collecting system. Maybe. You do have to scan all the way through, because if these connect at all, then it's probably not a dual collecting system. It's probably just a hypertrophied column of Bertin. Here's an example of a dual collecting system. Upper pole moiety has hydronephrosis and a little bit of hydroureter. That's actually aorta here, but the hydroureter comes down a little bit. Given the reason for hydronephrosis, the hydroureter probably goes all the way down to the bladder. I mean, not just the ureter, but hydroureter, too filled, goes all the way down to the bladder. The lower pole moiety is normal. And so these people, unfortunately, they're just at a higher risk of, well, not only really bad hydronephrosis, which kills the kidney from just hydrostatic pressure, but they're also more likely to get renal infections, UTIs going all the way up to the kidney. And a nice, beautiful dual collecting system on this person. This one clearly is not just a column of Bertin, but a dual collecting system. And yep, this one, 2 ureters all the way down. Although they seem to enter in the same spot, so that's probably pretty good. Oh, how did I not mention? Oh, okay. Sinus lipomitosis. So I wish I could write with this. Obesity. Atrophy of the parenchyma. Oh, and just being older. I forgot about that last one. Old kidneys can look like this. They're just simply, they're old. They're not going to last forever. The patient's in their 80s or 90s. And the parenchyma, not just the cortex, but everything has gotten quite thin. And if that gets thin, it's going to fill with fat. Or let's just look at this one, and let's just say this person is just obese, and obesity is going to just simply deposit more fat in the sinus. Not good for the kidney, because you don't want to squeeze this tissue out. So it could be obesity, and what else I have to say, and just renal disease. And none of these look like renal disease in particular. This is mild, really, sinus lipomitosis down here. This one is interesting, sinus lipomitosis and dual collecting system. So this guy's double whammy. There's our parenchymal defect. We see these guys all the time. You can see that perinephric fat kind of filling the space there. Or is it a scar? Look how this scar is wedge shaped. That means there was probably some kind of arterial blockage right here, and the kidney died in this location and created a scar. Granted, it looks like it's rather fat-filled, but oh, here's our extrarenal pelvis. So it's not technically hydronephrosis because look, I mean, the sinus itself does not have fluid in it. Maybe a tiny cyst, but in other words, a fluid's not here, but it is here. This is considered a normal variant. It's not considered a problem, but you do want to make sure that you're looking at it correctly. Now it draws. I made a mistake. As I look at that, I probably shouldn't have done that. I forgot I can't erase. I don't know how to erase these stupid things. That's not an extrarenal pelvis. I was looking at this incorrectly. I thought this was a transverse picture, and I was doing a web search of extrarenal pelvis, and it gave me this. But this is clear. This is a simple cyst because this is actually in the kidney. This is a sagittal picture here. This is the transverse picture. It's in. Well, I mean, it's a big cyst, so it's partially in, partially out of the kidney, but. My bad. That one's definitely an extrarenal pelvis up there, though. Now what? This is clearly hydronephrosis. Hydronephrosis fills these calyces, and they call this the bear paw. That's when you get major hydronephrosis. So this is kind of the pelvis here, major calyces, minor calyces, and it kind of creates this bear paw look to it. We'll talk more about hydronephrosis, hydroureter, I think tomorrow, I guess. And measuring kidneys, I think, yeah, this is the last one for now. Two different methods of measuring the kidney, well, two different caliper placements, I should say. This is the one I prefer up top here. Sagittal is sagittal. You're just going to measure the length. Transverse, measure height and width. Some people measure the sagittal and the height, the sagittal length and height in one picture, and then the width in another picture. That's all fine, and I used to do it too. The problem is that when you turn, and what I've seen people do is measure the length correctly, and then they'll take this measurement, and then they'll turn transverse and take this measurement. That's the same exact measurement, because you just simply you turn your transducer around. Let's just pretend it's AP. It's not really AP, but if it's this anterior posterior here, this is still anterior posterior. And so I've seen, and they measured it correctly. They went across, so they did fine. But I've seen plenty of people measure take the same measurement twice, and turn it in, and for years never even realize it. And I think the radiologists themselves they either don't realize it or they don't care. But we care because we're going to do things correct. Okay. Now I can't see my see my clock, 2:15, 2:30, 2. Well, let's just make it 2:45. This is easier. All right, so yeah, half an hour. So at 2:45, you guys will have an open book, open note tests. It is 20 questions, gallbladder and biliary. I think most of them are pretty straightforward. 20 questions, 1 minute per question, that would be 20 minutes. A minute and a half would be 30 minutes. So you will have 30 minutes to finish the question, to finish the test. I'm not going to stop you from going back. I'm not going to, a lot of the things that we could do to make things a little trickier, I really struggle with. So we're not going to do that. But we are going to limit your time and scramble the questions a bit. So, any